Good evening, everyone, and welcome to tonight's YESM Learnings webinar. My name is Mohammed Aburegev. Together with my fellows, I would like to welcome you all to tonight's webinar. For those who are joining us for the first time, I would like to briefly share the idea about this YESM Learning. The concept is simple but important. We want to create a platform where emergency physicians can come together to engage with clinically relevant topics, reflect it on their practice, and learn from both national and international colleagues. So YESM Learning is not just about webinars. It's about clinical reasoning, shared experience, and ultimately translating knowledge into an everyday emergency care, especially in a high-stakes situation. And tonight's topic, it's truly represents one of the most high-stakes moments and topics for me and for you as well. And let me take you briefly into a clinical scenario in general. Imagine that you're sitting in your ED, and then you have a code, a patient who's coding, and then come with the whole team doing the CPR. And when you see like they check all the CPR steps, it's going awesome. And the team is working efficiently, but the question remains like in your mind while you're looking at the team and working so well, why did the patient arrest? Is this a cardiac tamponade? Is it a massive pulmonary embolism, or it's ischemia? You have only seconds to make decisions that change the patient's outcome. And this where the point of care ultrasound become a powerful extension of our clinical assessment, or it's maybe considered to be a bad choice. Dr. Justus Wolff is an anesthesiologist also, and he has an emergency medicine heart, as he told us before in the pre-session. And he actively involved in the European emergency medicine education. He is a young emergency medicine lead in EUSEM and a member of the DGINA, the German Society of Emergency Medicine. He had brought very extensive experience in POCUS and in critical care. So that will guide us through how to integrate ultrasound into a cardiac arrest management in a way that support and not interrupt the high quality CPR. Yes, welcome on board. Stay with us, Dr. Justus. Yes, the scene is yours.
Well, I'm in the car again, and I'm really happy to see Justus again. He had a brilliant talk in EUSEM in Copenhagen last time we met. It was nice. I'm excited about today's topic, and I'm also excited because we have a new moderator with us tonight, Anja from Uppsala, Sweden. She's an emergency physician and a POCUS instructor, and she's also doing a PhD in catastrophic medicine. Do you say that? Is that even a word? Anja, welcome.
Thank you. So it's disaster medicine, and I finished a PhD. Yeah. So now it's
you finished
postdoc ahead. Yeah. Thanks.
Okay. We're happy to have you. And Rasmus, tell me about the rules for tonight.
Yeah, I always get that, isn't it? Tell people about the rules. Anyway, so we have a chat box. Please feel free to enter anything and all that you sort of a train of thought that you haven't finished, a clear question, anything that you want to bring up into the discussion, and we'll try to weave it in as we go along. I think that's everything from me. If there's nothing else from you, Mohammed, it doesn't seem like it. Justus, please take us away.
Awesome. Thank you, guys. Thanks a lot. And Rasmus, to get back to your original statement, you said you weren't using POCUS as much, and you were hoping for a little bit of structure maybe to get for using POCUS in cardiac arrest. And I think this is probably the core content of this talk. So for my background, like Mohammed said, I'm doing anesthesia on paper and emergency medicine in my heart. And I'm not in a huge academic university hospital at the moment. I'm in the military hospital in Berlin. So I would say it's like a middle sized hospital. And this is normally the reality for most professionals working, right? They're not in the huge, great, big hospitals with lots of staff and all the science happening there and research, but they're doing the field work, right? You're in the normal hospitals, and even there, it's really important to understand when to use new-ish technologies in new-ish scenarios, and to get a little bit of a mental model for that. So I have a lot of ultrasound loops for you guys today, and this is a two-way street. So I'm gonna ask a lot of questions, and you can write in the chat because I like interaction, even though I can't see you. I hope to hear from you as we go along. I've given this type of talk for some time now, and usually I start with like a very distinct patient case that I had a couple of years ago when I was still a student, 8 years ago. And just 2 weeks ago, a colleague told me a story. It was a colleague who only recently has been employing point of care ultrasound in cardiac arrest or peri-arrest patients. And this story, even now that I'm thinking about it, really gives me chills still. So this is what we're going to start off with. Imagine you guys are in a ambulance setting. So you're working as a pre-hospital emergency medicine physician, and you're getting called to a 42-year-old male with shortness of breath. Okay, classic. Of course, he lives in the 7th floor. Of course, there's no elevator. Of course, it's summer time. And of course, he's overweight. Yeah. So what we're getting to a patient, you know, that feeling when you walk through the door and you see the patient kind of like 10-meter distance, and in the first second you already know, okay, this is you know, in all the courses that you do, you would say, oh, this is a potentially critical patient. Yeah, but what I mean is your gut feeling is telling you, okay, this looks like shit score equals 1. Okay, so this patient is critical. The history is very limited. The daughter is with the patient. The patient is not able to talk anymore because he has such severe shortness of breath. And the daughter tells you that this patient just came back from a long-haul flight from Asia. He just arrived that day. He's had pulmonary embolisms in prior, like 5 years ago, and now he has sort of the same feeling, right? And as you progress through the history and you're trying to gain IV access, this patient actually arrests right in front of you, and it's a PEA arrest. Now the question, what do? We have a 42-year-old male witnessed out of hospital cardiac arrest. He's got good chances, right? Like arrested right in front of professional help. And what do you guys think? What could be the differentials here for this patient? Just write some stuff in the chat box. STEMI, okay. Nice. So STEMI is probably one of the most frequent events and causes for cardiac arrest. However, like a PEA arrest for primarily myocardial infarction, it's quite rare. You'd probably expect a shockable rhythm in that as an initial rhythm at least. And so you're saying pulmonary embolism, hypovolemia, okay. Pulmonary edema, that's great. Now, pulmonary embolism would be too easy, right? If this was a patient, let's be honest here, if this was a patient, 42 years old, arrested right in front of you, history and patient symptoms, everything is screaming pulmonary embolism at you, right? So this is a patient where I would consider thrombolysis, okay, in cardiac arrest if you're maybe a little bit further from the hospital. Now, they drew up thrombolytics, and then they decided, okay, let's quickly put an ultrasound probe on. And this is the image that they were seeing on ultrasound. So Rasmus got it right. Rasmus said tamponade, but I also have to say that Rasmus already saw this clip. So
I'm such a cheat.
that doesn't count. -1 point for Rasmus. All right, so this was a patient with pericardial tamponade. Under ongoing CPR, he was rushed to the hospital. Pericardiocentesis was tried, but was not working because there was a blood clot in the pericardial sac. So he was going on veno-arterial ECMO, so eCPR at the same time. They cannulated him, ECMO flow started, and they rushed him over to thoracic surgery. They opened his chest and did a thoracotomy on him, and 2 days later, weaned him off ECMO, extubated, neurologically intact survival. What's the story here? So this patient went to Asia, and without his family knowing, he had atrial flutter. That's why he had the PE previously, and he had a ablation for atrial flutter probably in Asia. And during the ablation procedure, they nicked a little bit of the right atrium. So they found a small hole at the right atrium to the IVC, which was leaking a little bit, but over time accumulated quite a bit of fluid. And that's how he went into arrest. So this patient, you definitely do not want to thrombolyze. And because of point of care ultrasound, they were able to identify the actual reversible cause here and get goal-directed therapy. And if we're being honest, point of care ultrasound in this instance definitely saved his life. And as my colleague said, it probably saved my colleague's life as well, because just imagine having a patient, a young patient like that with a very treatable reversible cause, putting thrombolysis on it, having the ultrasound in your bag, not using it. This, for me at least, it would be very tough if I had made a decision like that. Very tough to live with. So I think point of care ultrasound really can make a difference. And before we start with all the loops, we're going to do a little bit of the literature overview. So
could you, sorry, yes, there's to interrupt. There's one attendee that wants you to just basically go through the imaging that you showed before there, just to explain what's going on.
Absolutely. Let's do that. So as you can see here, you can see my laser pointer, right? So this is the heart that you're looking at, subxiphoid view. So we're looking from under the chest. We're looking up at the heart. This is the heart that's trying to beat and trying to eject some blood. And what you can see all around this here, all of the black stuff, that's blood in this case. We can just say it's free fluid on the ultrasound. So this is the pericardial sac, roughly. And there in the middle, you have a lot of fluid accumulated in the pericardial sac. And because you can see that, so this would be the septum, interventricular septum. This would be the left ventricle, which is very, very tiny. This is the right ventricle, which is flopping a little bit because it can't fill anymore because the fluid around it is pressing onto the right ventricle so much. So this is ultrasound findings of pericardial tamponade. This would be considered diagnostic of pericardial tamponade on ultrasound. And together with the clinical picture, you can say, okay, this patient is wildly unstable, right? He's in peri-arrest or already arrested. So this patient has cardiac tamponade. Thanks a lot for your questions. Please always ask like that. And Rasmus, you're always welcome to interrupt me to answer something. All right. We were saying a little bit of literature. What's the problem that we're trying to solve here with ultrasound? So we have roughly 10% survival to a hospital discharge after out-of-hospital cardiac arrest. We have 24% in-hospital cardiac arrest. And now if we look at the presenting rhythm, the initial rhythm in cardiac arrests, we roughly have like 75 to 80% of cardiac arrests present with non-shockable rhythms. And we know from the evidence that the shockable rhythms obviously are considered to, or not considered, but we know from the data that shockable rhythms have much better survival and much better neurologically intact survival if you compare it to non-shockable rhythms. Classic non-shockable rhythms would be pulseless electrical activity, PA, or asystole. So for shockable rhythms, how do we treat it? With electricity, right? We defibrillate. For non-shockable rhythms, it's a little bit more difficult because there's a plethora of underlying causes for non-shockable rhythms. And here, identifying the cause, cardiac arrest is not the diagnosis, it's just a symptom of the underlying cause. So identifying the cause, that is key. And that is going to make the difference in non-shockable rhythm patients. Now I have a little bit of a challenge for you. Yeah, I'm curious. So get your chat windows open. I'm going to send you a couple of videos again here. I want you to look at these ultrasound loops that I'm sending to you, and it doesn't matter if you have a lot of expertise on ultrasound or no expertise at all. I just want you to write in the chat box if you think that the patient who this ultrasound video belongs to has a pulse or doesn't have a pulse. So this is the heart that you can see. Do you think this patient has a pulse or not? You can just write yes or no. Yes for a pulse or no for no pulse. Okay, I'm seeing a lot of messages. No idea how to tell is one. Okay, let's go ahead and just replay that video. So you can see this is the heart. Usually patients with a pulse, not usually, always patients with a pulse have to have a moving heart under normal circumstances without cannulas inside of them.
Justus,
yeah.
can I just interrupt you and just say something about them? Because as we discussed a little bit before the session, the quality of the for the ones that are seeing this and not very used to ultrasound pictures, what you see here is a slower motion, and you see it a little bit window by window. So just to make sure that they understand this might not be, it is not what you see in real life. The quality here now is not really.
It skips every other picture, so it's rather sort of still pictures in row rather than a flowing video, unfortunately.
Okay.
So just
if
you're not so used to it, then understand that this moves a little bit more smoothly. So you have to just make that picture in your head a little bit. Sorry to interrupt you.
No, of course. So this heart here, as you might be able to see, you can't see any movement at all. So this heart is keeping very still, and it's not moving at all, right? And a lot of you said no, there's no pulse with this heart, okay? Which I think is interesting. So let's move it along, and so I have another video here. Maybe you can see that there's a lot of vigorous cardiac activity going on here. Is that visible a little bit? Yeah?
Yeah.
Okay, so this is the difference, right? So you can see that in this video, there's more going on. So chat, what do you say? Does this patient have a pulse? Yes or no? All right, I'm seeing a lot of yeses here. Whether there's a pulse or not is not sure. The heart is beating, absolutely right. That is the gold answer, so to say. And now here's the next video, which even if it's slowly, maybe you can see that this heart is beating slightly. It's beating only a little bit. Okay, so there's opening and closing of the valves a little bit, but this heart is not beating a lot. All right. And now, if you would ask me the question, does this patient have a pulse? I'd be like, I don't know. And we can see that patient has a pulse, patient has no pulse. It's not binary. It's not a binary answer to this question, but it's rather, it's a spectrum, right? You go from a patient who is very well perfused with a good blood pressure and good ejection of blood from the heart you go all the way to a patient who is very clinically dead and has no pulse at all. And in between, we have something we call shock. And at the moment, there's this paradigm shift going on that we think of PEA, of non-shockable rhythm arrests, more as just profound shock states, right? So these patients, they don't have a primarily cardiac problem usually with where there's a big myocardial infarction and the heart is not beating anymore because there's VF going on, so it's like fluttering. But instead, there's another underlying cause which led to profound shock, which then led to cardiac arrest. So this is the essence of what we're going to talk about next. So if I think of ultrasound and cardiac arrest, I think of this workbench. I really like Formula One races. Maybe you watch some too. And this is what the workbench looks like in Formula One. And I'm just seeing this question in the chat. Enis is asking, would we see opening of the valves if there's no pulse? That's a great question. Let me put that a little bit to the back because this is something that we're going to talk about in depth in a minute. Okay, so this is the workbench. Yeah, you have adrenaline up there, you have amiodarone, you have your defibrillation electrodes and everything. But as we progress into modern times, there's new stuff. So if you go into any mechanics workshop, you usually find this. This is the diagnostics machine. You know, if you have a new car, the car mechanic goes and plugs the diagnostics machine into the car and it spits out the error code, so you know what's wrong. This is a little bit how I think about ultrasound in cardiac arrest. Now, there's a couple of things that that we can do in cardiac arrest with ultrasound. It's usually these are the three big topics: echo during CPR, reversible causes checking, and there's also a pulse check with ultrasound. Now, today we're going to take a small in-depth dive into two of these topics. Into the first ones because I think these are the most important ones and the most applicable and make the biggest difference in daily practice. All right, starting with echo during CPR. We already had this analogy of the Formula One team that is attending a cardiac arrest, right? And I dug deep into my folders and pictures, and I found a picture of myself as a medical student when I was very excited about ultrasound, about cardiac ultrasound especially. I was a final year medical student. I did a little bit of shadowing or some echocardiography in the lab, and we in the resus room now. There's a cardiac arrest going on, and I'm asking my consultant, "Hey, is it okay if I put the probe on this patient? I just want to have a look at his heart." So mind you, this was probably, yeah, it must have been like 5 years ago, I think. I was not experienced at all in cardiac arrest ultrasound. So yeah, there I went into the Formula One team room where everything was going smoothly. Everybody was working, and I didn't know the people yet. I took my ultrasound machine and I put the probe in the patient, and the picture of me as a student looked something like this because I had no idea what I was doing. So this is what I looked like probably to myself and also to the whole team who suddenly had this new team member trying to help, not really knowing what they were doing. And from then on, the resuscitation went to shit, basically, and my consultant had to take me out again because I was very keen on getting the best view of the heart during the resuscitation, which was not the primary goal. And yeah, so that was my first story of how I did ultrasound and cardiac arrest. This is not how you do it. Important to remember, and this is also in the guidelines, echo during cardiac arrest does not have priority. Okay, first of all, the resuscitation has to run smoothly. And whenever you're in a small team, of course, you have to focus on proper chest compressions, early on defibrillation and oxygenation, which we know are the biggest factors and contributors to a good outcome for our patient. then if you're in a large team and you have the capacity, you have the resources, and you have someone who is knowledgeable and knows how to do ultrasound, then you can have one experienced POCUS operator doing it when you briefed the team before. So the team is not surprised by suddenly another team member with an ultrasound machine, but they know what's going on. Why am I telling you all this? This was a funny story of me, right? But if we look at the data, we can see that, and this was propagated a lot over the last years, that using ultrasound during cardiac arrests increases CPR pauses by 4 to 8 seconds. Okay, so we know we are limiting our rhythm checks to 10 seconds in cardiac arrest, right? And increasing that by 50%, that's quite a lot. And it's causing our patients' perfusing pressure and cardiac perfusion pressures and cerebral perfusion pressures to drop, and they take a longer time to get back up again. So this is not what we want. But the important factor here is without a structured protocol. So if you just run into the room, you do ultrasound, you're probably going to extend rhythm checks, might negatively affect your patient. After CASA implementation, so this is a structured way of doing it, they were actually able to reduce the time it took for rhythm checks by 4 seconds. So it was shorter. And we also know from the CASA studies and some other ones that if you place the probe during compressions on your patient, so CPR is still ongoing, and that's when you get your best view, you can remove 3.1 seconds on average, as opposed to everybody stopping, rhythm check is happening, 10 seconds are running, and then you only put the probe on and you're trying to get a good view. So preparation. And also, if you have knowledgeable people on board, then it's also shorter. Okay, so this is the important takeaways here. So a lot of times you can read in the literature or still in talks that ultrasound prolongs rhythm checks. I would humbly like to disagree and say people prolong rhythm checks because the ultrasound machine doesn't do anything on its own. It doesn't walk into the resus room and like get everybody away. It's people using ultrasound. So this is where we have to just teach proper structure algorithms. And this brings us to best practice. This might be the first slide worth taking a picture of. So this would be current best practice for POCUS and cardiac arrest. We're going to get one view. This means we're not going to do multiple different angles on the chest, trying to get different, at least in the beginning. If you're not very experienced, you just do one view, which would be the subcostal view usually for you, so subxiphoid. You limit to 10 seconds. There needs to be another person. I don't know if you guys maybe practice nurse-led code. We do that sometimes. So the nurses are actually stricter than the doctors, at least in my experience, at limiting the time for rhythm checks, which I love. I think it's absolutely perfect. And after 10 seconds, or maybe even after 8 seconds, they say, okay, ultrasound, go away. Okay. And then you have 2 more seconds to wipe the gel off your patient. So that the next person who does compressions doesn't slip and hit their head on the patient's forehead, which never happened to me. So always carry a towel with you. Yeah, so let's go through this. So one view, 10 seconds limiting externally by a timekeeper. We're using a phased array probe. We're going to pre-place the probe during ongoing compressions. So we get a view before the rhythm check starts. We're going to always record your images that you take as a loop. You don't try to interpret the images during recording. You take the ultrasound machine, you go in your corner, maybe you take a second pair of eyes, and then you look at the recording, so that during the rhythm check you can only focus on getting the best quality view that you can get, and your mind is not occupied with trying to interpret already the images. Is there pericardial effusion? How is the heart beating? What are the valves doing? So on, that doesn't matter. Record the video and then look at it later. Then you want to wipe the gel, and very important, team briefing. So the team needs to know before the rhythm check that, okay, we're going to do a ultrasound. Yeah, so that people are prepared. All right, this is our probe. And who's this? I need your help. Anybody know? Who's fastest typing? Yes, Federico won. Awesome. Awesome. Okay, Federico said Bruce Lee. This is Bruce Lee. Bruce Lee has one of my favorite quotes. Bruce Lee said, "I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times." So we're going to do everything standardized, everything the same. We're going to use the echo probe, and we're going to go subxiphoid as the view every single time. Okay, starting off so that we get really good at this. Let's have a look at this recording. So this was one of the resuscitations where I was present. I don't know, it's been some time, and as you can see, probably also if the images are a little bit stuttering, you can see that in the beginning, which would be now, so in the beginning, the heart is not fully in view, right? You can see the heart is not fully in view on the ultrasound. And then after the rhythm check starts, I have to adjust my depth. So I have to increase the depth so that I can see the whole heart. That's not how you do it, okay? So the whole goal of putting your probe on the patient before you do the rhythm check is that you perfect your picture, the quality, your view before the rhythm check starts. So what I should have done is put the probe on and then already adjust the depth so that I can see the whole heart, adjust my gain accordingly so that I can see the picture clearly, my focus position, all of that, so that I have a crystal clear picture as soon as the rhythm check starts. Yeah. Now, what does a normal echo look like? Does echo look like during cardiac arrest? Let's take a quick patient case. So we have a 70-year-old female with a PA unwitnessed arrest, and we're going to the patient. We're putting the probe on, and I mean, in this video, you can see there's just a lot of compressions going on and you can't really see anything at all, okay? So this is the time, 20 seconds before the rhythm check where it starts, and there's just a lot of movement going on and I'm trying to get my proper view, okay? Then as we progress, I'm increasing my depth here, and there's still a lot of compressions going on. And now that I've perfected my view, the rhythm check starts, and I can see this is the same image that we saw as one of the first ones. We can see a perfectly still heart, okay? So there was no cardiac activity in this case. And then 10 seconds are counted down, and compressions start again. Now, if we take a different patient, 60 years old, PA witnessed out of hospital cardiac arrest, and we put our probe on during the rhythm check for this patient, we can see, oh, okay, now here there's a lot of movement going on. So I see a lot of cardiac activity. Maybe we should check if we have a pulse. We should check our ETCO2. If we put an arterial line, and we would probably see already blood pressure in this patient. If we don't, then this is a patient in profound shock, because we can see the heart is moving. There's organized cardiac activity. The definition of that we'll get to shortly, and we can treat accordingly. Now, the cool stuff, reversible causes. We said 80% of cardiac arrests, non-shockable rhythms. What are the reversible causes where ultrasound can really make a difference? I've taken the H's and T's, even though it might not be the most modern thing to use still, but it's still in the guidelines. So let's look at this. We have generally speaking, four reversible causes that are very nicely identifiable with ultrasound. And this I'm going to get into a little bit so you get a feel for what it looks like and what to look for in cardiac arrest if you want to identify these. Now, it would be too easy if I told you what you see. Now, the quality of the transmission, of the internet transmission, might not be as good, but I'm pretty confident that you might be able to guess what you're seeing. So, first reversible cause. This is the loop that you can see during the rhythm check, during CPR. There's no movement at all. We're looking at the heart. This is a difficult one, actually, to start with. It's from a recent case. Anybody have an idea? I'm gonna give you a second patient. Oh, hypovolemia. Nice. All right, Ahmad got it. Awesome. So what you can see here, I'm gonna take my laser pointer. You can see this is the heart, and it's completely empty. We do not see any fluid inside the chambers of the heart. So this was a patient in traumatic cardiac arrest after a fall from height. We arrived pretty quickly to the scene, but the patient was already in cardiac arrest, and the heart was completely empty and was not beating at all anymore. And there was no electrical activity on the heart. So we decided against any invasive measures in this patient. We tried to give a little bit of volume and do the conservative traumatic cardiac arrest package, so to say. But yeah, the heart had no activity at all anymore, and it was completely empty. So this is hypovolemic cardiac arrest for you in its extremest form. Okay. Another patient with hypovolemia, you already found it. So this is a heart that is also beating only a little bit, only a tiny little bit of cardiac activity visible here. And it's very small. You can see the right ventricle almost empty. Anya, how are we doing? Can you see this a little bit with the laser pointer?
Yeah, I think it looks okay.
Okay, perfect. And the left ventricle is also pretty empty. Okay, so this would be another patient with hypovolemia as reversible cause. If we take a look, generally speaking, hypovolemia in ultrasound, what does it look like to us? So we have a very small left ventricle plus minus right ventricle, which is hyperdynamic. That means that the walls, you can call it kissing walls too, because the walls are clapping, because there's so little fluid inside that the heart is contracting completely, basically, and it's pumping empty. Or as we saw in the first video, the heart is completely empty and there's no cardiac activity anymore, which is associated with very poor outcomes, which we'll come to in a bit. Then we have a very flat collapsible inferior vena cava. And we have sometimes in our patients, we can see free fluid. Now for free fluid, we would do an EFAST usually. I'm sure most of you are familiar with the EFAST, and this is what it looks like during chest compressions. So this is a view, a normal view of the left upper quadrant, and you can see there's a little bit of movement going on, but I can still interpret the pictures very nicely. So EFAST, very possible during ongoing chest compressions, during cardiac arrest. And what you might find is something like this. During ongoing chest compressions, free fluid in the abdomen, and then there is this structure here. Does anybody have an idea what this structure in the middle of the abdomen could be patient in cardiac arrest, free fluid in the abdomen, and there's this aortic aneurysm. Federico, nice. Yeah, so this was a ruptured abdominal aortic aneurysm. And yeah, through ultrasound, you can identify this. If this changes the course of the patient is on a different page probably, but yeah, very, very nicely visible here. This is another loop of the same patient now with stopped compressions. Okay, so you can see this big black ball is the aorta. It's not supposed to be as big as that. This is the aortic aneurysm. All right, hypovolemia, check. Next one. This one is easy. Let's see what's happening here, guys. Yes, tamponade. Awesome. A lot of people typing this already, pericardial fluid. Perfect, yeah. So this is a patient with tamponade. We've already seen another loop of this. So just to clarify, this is the heart that we can see with the septum, right ventricle, left ventricle, and there's free fluid here, all this black stuff. And up here, free fluid in the pericardial sac. So this is a pericardial effusion, not quite as large or as hemodynamically relevant probably as the first video that we saw. But this loop just to give you another input. All right, pericardial tamponade, very rare, right? No, not quite. We can see 4 to 15% prevalence in PA arrest. And we're missing a lot of these people. There's been a study in Berlin too, a forensic study that showed that a lot of patients in traumatic cardiac arrest, but also medical cardiac arrest, had missed tension pneumothoraces or cardiac tamponades. So this is a very treatable reversible cause if you're within the right setting. And cardiac tamponade is one of the best ultrasound findings. Okay, so experienced emergency physicians have roughly 95% sensitivity and 98% specificity to diagnose cardiac tamponade on ultrasound, which is really high, right? And if you have your PEA arrest patient, usually they have a very poor prognosis, but if you see they have cardiac tamponade, they have a 15% higher survival to discharge versus the other PA causes. So this is a very relevant finding as well. Yeah, single most actionable POCUS finding. And just as a clinical pearl, if you have a cardiac arrest through tamponade and you don't know where it's coming from, think aortic dissection or maybe a atrial flutter ablation somewhere in Asia. All right, next reversible cause. Here we go. Are you ready, guys? All right, go ahead. Type your best guess. This is expert level, I would say. Right atrium is enlarged. Federico is saying. Okay. PE, Veronica is saying. What do you think? Another one saying PE. D sign, yeah. Okay, the D sign, I can't see the D sign on a subxiphoid view per definition. Has to be a peristernal short axis. But yeah, another one saying PE. So what we can see here is a very large right ventricle and a very small left ventricle, if you look at them, yeah? Usually you would say you want 2/3 of the diameter of the heart, 2/3 should be left ventricle, roughly, and 1/3 should be the right ventricle. And as soon as it goes like over 50%, so as soon as the right ventricle is larger than the left ventricle, there's something weird going on. Can be acute, can be chronic, but in this setting, very enlarged right ventricle, right? So this is a patient with a pulmonary embolism. That's exactly right. So 4 to 8% of cardiac arrests are caused by pulmonary embolisms. And we have up to 30% in selected populations. So that would be obese people, people with cancer, people who are immobilized and didn't take their syringe shots in their stomach. Yeah. And how can we have a look sonographically? We see a dilated right ventricle. We see distended inferior vena cava. Sometimes we can see a visible embolus in transit in the heart. And this is an absolute game changer for me, at least. You should check for distal vein thrombosis on femoral vein ultrasound. Okay, which is, if you have that skill, this is an absolute game changer. I'm going to get to that in a second. First of all, why did I put this asterisk here to dilated right ventricle? It's because RV dilation is a normal finding after the first minutes in the arrest, okay? So as the arrest progresses and there's no pulse and there's no cardiac activity, the right ventricle enlarges throughout the minutes. So you say like the first 3 minutes, if during the first 3 minutes, there's a huge, so of the arrest, so would be like a witnessed cardiac arrest, and I get to put the probe on the patient within the first 3 minutes after collapse, and the right ventricle is huge. Okay, this is a good sign that this patient might have a PE. If after 10 minutes I come to the patient and I put the probe on and the right ventricle is enlarged, it's not a good sign anymore. Let me show you this video. This is a pig heart, and they induced in this live pig heart, they induced ventricular fibrillation. Okay, so you can see as the cardiac arrest here progresses, we're looking at the right ventricle. You can see just how distended the right ventricle gets. Okay, so this is a time lapse. Yeah, from the beginning, time lapse, and you can see just how large, how quickly the RV gets distended. And it's the same in humans, essentially. Yeah, so our ACE.
Can you clarify there? So for the first minutes, the right ventricle blows up. So if you get that with your probe early, you'll see a distended right ventricle.
So during the first 3 minutes, if we have a patient who does not have a PE, during the first 3 minutes, slowly the RV begins to distend. So if within the first 3 minutes, I have a very large right ventricle, that's not normal. That is in favor of a pulmonary embolism. Now, if we go beyond 3, 4, 5 minutes, in every cardiac arrest, basically, except maybe for hypovolemia or something like that, as we progress over 3, 4, 5 minute line, the RV distends normally in all cardiac arrest patients, and then it's not as diagnostic anymore for a pulmonary embolism. Okay, but I can also think the other way. So if at minute 6, let's say, I look at the heart and the right ventricle, so in cardiac arrest patient, in cardiac arrest, PA arrest, and the right ventricle is not distended, that speaks very much against pulmonary embolism. So I can still rule it out. So I can go the other way around, right? So Kyle is asking in the chat, are there any studies showing pre-hospital providers using this or white papers showing improved outcome on these causes? Love the reversible causes. That's an awesome question. Let's put it at the back. Could I ask Anya maybe just to capture it, and we can talk about it in the end? Because I'm giving you a little bit of evidence to outcome and POCUS. So if you have the skills, you can do this. If the loop doesn't load properly on your device, what we're seeing is a DVT, awesome. Emre got it at first. So this is femoral vein, common femoral vein ultrasound, and we can see that this vein is not compressible. Okay, so normally you would be able to compress the vein completely. Here there's a clot in between, so you can't compress the vein, which completely changes the chances for our patient. Maybe we only got there after 10 minutes. We can't do the right ventricle stuff anymore because we're past that point. So we have a big right ventricle after 10 minutes. We're like, could be a pulmonary embolism. I don't really know. We're doing a femoral vein ultrasound and we're finding a clot, okay? And suddenly our patient has a positive likelihood ratio of over 16 that he has a pulmonary embolism. Okay, in half of all patients with a massive PE, you can find in the femoral vein, you can find a clot. That's quite high of a number, right? So now if I have the time and the resources in every patient where I think, okay, this could be PE, or I have the time and resources and I'm bored, at some point during the resuscitation, you're like, well, we did this, we did that. What else? I just put a probe on the femoral veins and sometimes you can find a clot there and that drastically changes the course of the resuscitation, right? All right. And if you're lucky, during cardiac ultrasound, you can find something like this. Does anybody have an idea what we're seeing? Let me give you another view where it's visible, better visible. So again, we're looking at the heart from subxiphoid, and there's something going on here. Let me give you another view. Right ventricle clot. Yes. Nicely done. It's an embolus, okay? So we can see here inferior vena cava. And this goes into the right atrium here. And this is not supposed to be there, okay? So you can see the washing machine starting up here. So this is a clot in transit. Yeah, clot came from somewhere, probably the legs, and is in the right atrium at the moment. And chances are that a lot of clot is already in the lungs at that point. Okay, so sometimes you can find this. All right. Next reversible calls, guys. Last one, if I counted correctly. What's going on here? What are we looking at? I don't see anything. I don't see any organ. I don't see a vein. I don't see a heart. What's happening? Oh, okay. Ahmad is saying pneumothorax. Yes, absolutely. Pneumothorax. So does this patient have a pneumothorax? All blood, Kyle? Not quite. Blood would look black. Okay, so here we can see something that looks black, which is, let me pause the video for a second. So you can see this. These are the rib shadows over here. And in between the ribs, we can look at the lung. So the probe is placed somewhere on the chest here at the highest point of the chest. And now the question is, do we have a pneumothorax or not? So lung ultrasound is a little bit also of an advanced topic, but Inti is already saying, hey, we have B lines here. If we have B lines on our lung,
would you mind just pointing out with a laser just to show everyone? So you were saying you're looking up here, right? And then just show them where the ribs are and pleura and everything so they follow. Thanks.
100%. So I thought I had it on, but I didn't. So these are the ribs over here that are casting shadows down. This is just a shadow behind the rib. That's completely normal because bone doesn't transduce ultrasound waves. Again, here, a rib shadow. And this would be a pleura line with the lung behind it. And you can see in the loop, you can see B lines. So that means you have white lines. Let me play the video again. You can see them dancing around a little bit. So there's everywhere, there's like little small white lines, which are a correlate for, let me find a nice, so here you can see a nice one. So this would be a nice B line. Yeah. So that would be pneumothorax or no pneumothorax? Question for you. No pneumothorax, Samir is saying. And that's exactly right. Okay. So usually in lung ultrasound, we do very fancy stuff. We look at lung sliding and we look at the lung point. And so it's a niche topic, lung ultrasound. But we can make it very easy in cardiac arrest because usually in cardiac arrest, we have a very wet lung because the heart isn't pumping anymore, right? So we get pulmonary edema. Pulmonary edema we can see as B lines. And whenever we can see B lines on the ultrasound like this, we know there's no pneumothorax here. Okay. So looking at the data, engine pneumothorax, if we do lung ultrasound for the pneumothorax, we have 94% sensitivity and 100% specificity if we are proficient at lung ultrasound. Again, this is sort of like its own niche topic, lung ultrasound, so you should probably practice before to be certain that you can rule out pneumothorax in cardiac arrest. Okay, so either we do lung sliding during the chest compression pause, during the rhythm check, or we just check during ongoing compressions. We check for B lines. If there's B lines on both sides, we know there's no huge pneumothorax, so no tension pneumothorax as the reversible cause. All right. Now, lastly, I want to give you a few clinical pearls. What we sometimes can see, speaking of shockable rhythm, we know that there's asystole on the monitor, but if we do ultrasound, we can identify some. So there's different numbers here, but different studies. But we can identify up to like 5% of patients who have asystole, asystole on the monitor and actually have a shockable rhythm, or we can see 35% ECG asystole with cardiac motion on echo. Okay, which is a game changer if we do it, because asystole patients traditionally have a very poor outcome. But if you can, so this is going to be a hard video to see, I think. This is essentially the heart, looking at it from the side of the chest. So it's a parasternal long axis view. And you can see here the mitral valve. It's sort of doing this. So it's fluttering around. Okay, can you see that a little bit in the video? Very nice. Okay, awesome. And this is diagnostic of ventricular fibrillation. Okay, so this, or yeah, it's probably VF. It's a shockable rhythm. Okay, so sometimes you have very fine VF going on the monitor. You're saying, okay, this is asystole, but actually you can shock it. And suddenly these patients go from asystole, very poor outcome, to shockable rhythm, VF, and we can put some Edison medicine on the patient, and they have a much better outcome. All right. Cool. Then we're going to cardiac activity and prognosis. This is really important, and this can really make a difference. True PA versus pseudo PA. We looked at a lot of hearts today, and I want to leave you with this clinical pearl that we said earlier, okay, we have the group of non-shockable rhythms, but the underlying cause is very important. What's also really important is before echo, before ultrasound existed, we were only able to see what's the electrical rhythm doing on the monitor. Now with ultrasound, we can look inside the chest and we can see what is the heart actually doing. So it is a very big difference if we have a potentially perfusing electrical activity and the heart is not doing anything. Yeah, maybe because it's just, the patient is just dead and the myocardium is not moving at all, versus we have the same rhythm on the ECG, on the monitor, but the heart is in pericardial tamponade beating but can't eject blood, or massive PE, something like that, suddenly it's a game changer, yeah, because suddenly our patient has a chance if we identify this reversible cause. So if we look at this list, every patient has no palpable pulse, hopefully, in cardiac arrest. Otherwise, we didn't diagnose it properly. In PEA, we have organized ECG activity, so potentially perfusing ECG activity. And now the difference is that in true PEA, what we used to call PEA, we do not have cardiac motion on echo for prognosis. Contrary to if we have pseudo-PEA, then we have cardiac motion on echo. Okay, so we look with the probe onto the heart in our PEA patients. If there's no cardiac motion, we are in actual PEA. If there is cardiac motion, we're in pseudo-PEA. True PEA is also called PRESS, stands for pulseless with a rhythm with echocardiographic standstill. And pseudo-PEA we can call pulseless with a rhythm. So rhythm means electrical rhythm with echocardiographic motion. Okay. Pseudo-PEA behaves prognostically almost like our shockable patients. Okay. So prognosis-wise and reversible cause-wise again, we can uncover with the help of ultrasound our pseudo-PEA patients. Let's quickly look at some loops here. True PEA looks like this. Heart is not moving. You can see the valves are a little bit moving. And now getting back to the question earlier by someone in the chat, if the valves are moving on ultrasound during cardiac arrest, that does not equal cardiac motion. That's very important to understand, because also a lot of the studies that have been done over the past years have inconsistent definitions of what is actually cardiac activity. And now, over the course of the last years, there has been one definition that has been broadly applied, which is cardiac activity means we have synchronized myocardial activity with a change in the diameter of the ventricles. Okay, so the important part here is change in the diameter of the ventricles. A lot of times we can only see in our patients the valves are a little bit moving. Maybe the myocardial fibers are moving a little bit, but there's no real change in ventricular diameter. And these are true PEA patients, okay? Just because the valves are doing a little bit does not mean that it's pseudo-PEA, okay? This is PEA. Another or same patient, if you now give them adrenaline, this is the same patient. What does it look like? We still have a PEA patient with a couple of bubbles in his heart, which is the adrenaline going in. We see a little bit of like movement of the myocardium, but is there a change in the diameter of the ventricles? Still no. So this is a patient even after adrenaline. Adrenaline, you know, like you have a little bit of activity going on in the heart. You see that a lot, but didn't help this patient. He's still dead. Contrary, true pseudo-PEA looks like this. You can see in this loop that the ventricles are changing the diameter. If you're new to echocardiography, this might be difficult to see. But if you do a couple of echoes, then you get a feel for it. So here, the diameter of the ventricle is changing, and there's organized activity. Okay, so it's beating at a reasonable heart rate here. Okay, or another example for pseudo-PEA would be pericardial tamponade again. Watch out for positive pressure ventilation. If you're doing echo during your pulse check, a lot of times, just because of the changes in intrathoracic pressure through the ventilation, you can see passive blood flow going into the heart and maybe out of the heart. That is not cardiac activity, because again, the diameter of the ventricles aren't changing. organized. You can see here there's bubbles going in and out of the heart. Can you see that a little bit? Yeah, nice. Okay. So do not mistake this with cardiac activity. And also this here, it's just a picture. You can see blood clots in the heart. So this is a patient post-mortem with already big clots in the heart, no cardiac activity. So this patient has been down for a while. Now, if we're predicting ROSC, we can see that if we have cardiac activity on ultrasound, ROSC 3 times as likely, survival to admission 3.6 times, survival to discharge 5.7 times as high. Okay, in our PEA patients again, yeah. And you can see here 0.6% survival to a hospital discharge only in the group that had no cardiac activity on ultrasound. So survival is very poor. Okay, so suddenly we can sort of see what the heart is doing, and it seems to be a good prognostic factor, but the evidence is still very limited. If we take all the evidence that we have currently and we pool it together, we can see outcome ROSC, survival to admission, and survival to discharge. We can see the odds ratios here, which are quite impressive, I think. This was all non-traumatic patients, the data from non-traumatic patients. And I think there's a lot going on at the moment in the researching prognosis and trying to add to the big clinical picture when it comes to prognosis of cardiac arrest patients with ultrasound. However, in the guidelines, there's still big fat bold letters: do not use ultrasound as a sole predictor for predicting the outcome. Obviously, okay, now this disclaimer is out of the way. I said it, but obviously we're never taking only one paper, or we're only taking one diagnostic tool to tell us about the possible outcome of the patient. Okay, but now what's better if you have a myocardial infarction patient, okay, chest pain patient, and you have a weird ECG, you go to the cardiologist, you show it to the cardiologist, right? And you're like, hey, what's going on here? And the cardiologist looks at you and he goes, well, I don't know, but do you know what's better than one ECG? 2 ECGs, right? So we're always doing serial ECGs. We obviously always are doing serial POCUS. So if we're doing serial POCUS, so echo after multiple rhythm checks on the same patient, this is what they did. We can see that 12% only had ROSC without cardiac activity. And if we delve into the details here, what I think is really interesting, the mean in patients with ROSC was only 2.8 minutes of cardiac standstill if they had ROSC, 19 minutes in patients without ROSC, and patients that had cardiac standstill on ultrasound for 5 rhythm checks or 10 minutes, over 10 minutes, 0% ROSC. If you take over 6 minutes standstill, cardiac standstill, yeah, even after administration, guideline conformed administration of adrenaline and so on, 0% survive to hospital discharge. Small numbers though, still. So the disclaimer also for you to read. The guidelines are very clear on this. Looking at trauma versus medical and traumatic cardiac arrest, it seems to be a little bit better. Ultrasound at predicting, so this is what we actually want to do, right? We want to predict patients dying. We want to predict bad outcomes. We want to predict failure of ROSC. In traumatic cardiac arrest, when there's no cardiac activity anymore on ultrasound, there's 98% specificity that this patient will not get a ROSC. Which is why I'm curious about your like areas where you work in, but I know a lot of HEMS providers, or so pre-hospital as well as in hospital, that have incorporated ultrasound into their traumatic cardiac arrest algorithms, and are saying, okay, if we have no cardiac activity, we're not going to do resuscitative thoracotomy. We're going to withhold some interventions in those patients. So in non-traumatic cardiac arrest, the specificity is a little bit lower, okay, just because it's a whole different patient cohort. All right, so summarizing, process goes as follows. Before we do ultrasound and cardiac arrest, we brief the team. We assign one skilled operator onto the POCUS role. Machine on phased array probe. Set your depth, set your gain, set your focus nicely so that you have a good picture. Put your probe onto the patient during ongoing CPR. Yeah, put the gel on, find your acoustic window, optimize the settings. Then the pause starts. You're going to record your clip. You're going to get externally, not yourself, but someone else is going to count the time for you so that you have more cognitive resources to concentrate on the ultrasound. Then you're going to wipe the gel off the patient. Remember, don't let your colleague slip. Then you're going to resume compressions. After the pause, you can review the recorded clips, get a colleague to look at them with you together. 4 eyes find more stuff than 2. Communicate the findings to the team, and then you plan the next pause. In general, we do have to say, though, evidence quality still is pretty low. For ultrasound and cardiac arrest, most data is observational. We have one RCT, which was quite small, and it showed no difference using ultrasound in cardiac arrest, no difference for patient outcomes, which is what we are aiming for, but probably one of the most difficult parameters to find a difference in. So the potential is impressive, the evidence quality, not yet. Key takeaways. This is another slide you can take a picture of. Tamponade and pneumothorax, they're absolute game changers and very easy to diagnose. Cardiac activity predicts ROSC. Think of the RV. Yeah, 3 minutes maybe as a cutoff, 4 minutes as a cutoff. If before that time you see a very distended RV, think pulmonary embolism. Afterwards, think, let's look at the legs. Limit your pause. Pre-place the probe, designate the timekeeper, and wipe the gel. Don't use POCUS alone for anything, obviously, and train and simulate, as always, before you deploy this in real codes. So try to employ it into your code training. Even if you just have a mannequin, just put the ultrasound machine there and you'll see, okay, this is bad. If I place it here, it's going to interfere with like the chest compression, rotation, or something like that. So always test it before you do it on the real person. Yeah, may ultrasound Bruce Lee be with you all.
Amazing. Really, really good talk. Really enjoyed that. Thanks a lot. Anya, did you have any, we're well over time, so any participants that need to leave, we're not going to hold you accountable for leaving at this time. But Anya, did you have any pending question after you were supposed to hold on to some question, wasn't it?
Yeah, it was a question at 1953 of Kyle Henson in the chat. Are there any studies showing pre-hospital providers using this or white papers showing improved outcome on these courses? And I think one difference here is that just as you work in a German setting where you work pre-hospital quite a lot, don't you? A lot of the anesthesiologists and some ER docs in Germany do that, and we don't really have doctors pre-hospital like that, so it might be a difference. But would you address that question briefly? If you want to read it, it's in the chat.
Yeah, I just did actually. So there's no study that I'm aware of showing directly improved patient outcomes from pre-hospital POCUS and cardiac arrest, because we also don't have that in hospital yet. What I think is quite interesting is that there's some study done with because you just hinted at this, that there's a lot of emergency physicians working pre-hospital in Germany. There's now with telemedicine the modality that paramedics do cardiac arrest ultrasound, and via telemedicine they send it into a physician in the ED, and then the emergency physician helps interpreting the ultrasound images, which I think is really interesting. I love paramedics doing ultrasound, and it's very easy to learn. It's a very steep learning curve. However, I think if you want to do proper cardiac arrest ultrasound, you need a lot of experience. And probably it's easier to get this experience in the emergency department just because you see more cardiac arrests. So sending these images and loops live to physicians in the emergency department so that they can help interpret them and give clinical advice, I think that's absolutely amazing. That's the future. Yeah, and getting back to the prognosis question. So I think the core problem here is that we know cardiac activity on POCUS predicts ROSC and survival to hospital admission and so on, but that's prognostic association. It's not a treatment effect, obviously. So seeing cardiac activity doesn't cause survival. We just know, okay, there's an association between this. So we need to make sure that we don't prolong rhythm checks and so on with ultrasound, so we don't negatively affect the CPR performance. Yeah. So maybe to add to that, just as a last sentence. So we don't have the data yet, proving that POCUS helps with good outcomes in cardiac arrest, and honestly, I think we probably never will from an RCT because it's very difficult to distill this down as the sole contributor. Or it would be very difficult. I'm interested what you guys think about that.
It's probably difficult. Can I just ask you, because we have in the chat a question whether or not they can email you with specific question after the webinar.
Yeah.
Would that be okay?
Yeah, I'll send you my email quickly.
If you could put it in the chats for
Yeah.
the participants to see, yeah. So people seem to really have enjoyed this talk, as did I. However, I have to leave now, but I really appreciate it. Super well, and I'll definitely go sort of to, I use POCUS a lot, but I will definitely try to get it more protocolized, especially in cardiac arrests in this, and using it more with the kind of evidence that you've been able to share with us today. So appreciate it. Thanks.
I totally agree with you, Rasmus. We are using POCUS like here and there in the small areas to be aware of in the future, like to use it in a protocol.
Yeah,
not as a rubbish. For me, mostly.
Can I ask a question, Justus? Do you still have time?
Yeah.
Do you think the use of mechanical devices during cardiac arrest change the protocol that you are using, like switching the 10-second rule and so on and so forth? Do you think the wiping the gel and do you practice with a mechanical device, or do you have mechanical devices that you use regularly in your hospital?
Yeah, so we have the Lucas and the corporal CPR because we have both devices, sometimes in hospital, sometimes pre-hospital. Personally, I like the corporal CPR for this purpose better because the Lucas, like, what do you call it? Like the stamp thing. It's quite large, and sometimes it hinders you from, or let me get the other way around. So a lot of times I find that you can adjust the Lucas to go a little bit lower on the chest, which will get you better ETCO2, better diastolic blood pressure, and so on, because then you're not as much over the LVOT anymore, but over the left ventricle, and you just get better chest compression effect. But then because it's quite large, it's over your subxiphoid view, and it's hard to get ultrasound picture. Again, if you use other devices that have a smaller stamp and that's adjustable, then that usually works better. Yeah, so I guess the answer to your question from my side would be sometimes the mechanical devices can block the view because you can't get the proper probe placement sometimes. But other than that, I didn't feel it has a big effect on whether you're able to do the ultrasound in cardiac arrests. I'm curious what your experience is in that.
Well, yeah,
seen it.
yes, I think that's as usual with all the devices. It's hard to get the proper training, and it is so much focus on the machines that you sometimes just I mean, forget how to do things manually, and you when you train, you usually, or when you practice, you usually practice with manual compressions, and because it's hard with a mannequin, I think, to practice the actual skill and to get the views, the proper views. So when you and it's, I think you need to practice both ways with mechanical and human compressions. So it's just interesting how you and we had another talk with the when we talked about the compression, and when, as you said, the compression device is actually the thing compressing. The placement of the thing compressing is very important, and sometimes it's in your way of your ultrasound machine. And obviously, it's hard to get the full EFOST look with at least the Lucas device, I guess.
Yeah,
process easier. So.
Yeah, exactly, and exactly what you just said. I think there's the combination of two skills that you have to master. It's you're practicing your ultrasound skills, just getting a lot of subxiphoid views on patients so that you're very proficient in getting this view. And because you can't do it on mannequins, like you said, there's no heart in the mannequin, most cardiac arrest mannequins at least. And the second one is you're practicing the team and the procedure and the algorithm structure, organizational side of things. If you use ultrasound in cardiac arrest simulations, which arguably is probably equally important, so that that the whole cycle and your team knows how this works, and it can be also really changing for the team. For example, if you have a traumatic cardiac arrest patient, and we always used to do chest compressions on traumatic cardiac arrest patients. Now, sometimes you omit that because okay, there's an underlying reversible cause and it's not a cardiac cause, so you don't do chest compressions anymore, which for a long time it was very difficult to communicate, or at least for me to communicate this to the nurses or paramedics. Hey, we're not going to do chest compressions on this cardiac arrest patient because we have to concentrate on the traumatic cardiac arrest algorithm. But if you do an ultrasound on these patients and you can show your team, hey, look at the screen, the heart is beating, then everybody suddenly understands, okay, yeah, he doesn't need chest compressions. And there's no big fuss anymore.
I need to leave in a minute as well. I just wanted to say I really like that you discussed the DVT thing, because it can actually change how you think about the case. And also, sometimes when we discussed and you really pointed out the difficulties when getting access and then not delaying anything, but the legs are usually free for you to kind of use. So you're not getting in the way of something, so you can actually do that in between and other things are being done if you have the right size for the team and everything. I just also wanted to ask, because the numbers, I haven't read the studies that you referred to, but what about age? Because I mean, for us in quite big city, in the middle of Sweden, we get a lot of elderly population. So most cardiac arrest are elder patients. And does that do anything with how you would use the ultrasound or think about it? Or the causes to it?
Interesting question. I don't think it would.
In the studies, do you know the age number, like the studies you refer to, and the outcomes and the numbers? Do you know what kind of populations they've been done on?
I don't know. I would have to look that up. I think it's normal populations.
Right.
And I mean, probably what changes is not necessarily ultrasound, but just the pretest probability of the reversible causes, right? So elderly patients have higher rates of cardiac ethology with myocardial infarctions and acute valvular failures, higher PE prevalence. They're more likely on anticoagulation. That too, they have more aortic pathology. So I would guess that the diagnostic yield of POCUS for reversible causes in the elderly can be high too. However, I'm interested how you do it in Sweden, but in Germany, very soon in a cardiac arrest in an elderly person, you would probably prioritize looking at goals of care and patient will. And then maybe you don't have the time necessarily to do like an extended point of care ultrasound exam because of that, because you're prioritizing sometimes, are we continuing resuscitation at all in this patient? What's your thought on that?
Well, I think quite often we use the ultrasound as a help to maybe stop sometimes. That it adds to the I mean, not solely depending on ultrasound, of course, but if you have a really, really bad contractility on the ultrasound, then that really adds to the full picture that this might not be. So it's actually helping us to terminate the CPR and the whole resuscitation, I think.
Yeah, absolutely. I mean, if you have cardiac standstill at 10 minutes going into a cardiac arrest in a 40-year-old, you'd probably keep going. If you have the same thing in an 85-year-old with cancer, or maybe not with cancer, then maybe you stopped earlier, but then you would probably omit resuscitation efforts. Yeah, that makes perfect sense.
Yeah. Guys, I have to leave. Thank you so much, Justus. It's been a wonderful seminar or webinar.
Thank you so much, Justus. It's a really wonderful speech. Thank you, Anja,
Thank you.
for with us. And I have some questions regarding the right ventricular enlargement, but I'm gonna text you, Justus, tomorrow about them. Okay, because we're running out of time.
Okay.
It's really interesting for me. Okay. Thank you. Take care. Bye-bye.
Thank you.
Thanks. Otherwise, just email me. Yeah.
I will.
Nice to see you again, Justus.
Absolutely, Tobias. See you in Paris.
See you. Yeah. We'll
Take
see.
care.
Bye.
Bye.